So I would like to welcome all of you on behalf of MPSOS and Chhattisgarh Ophthalmic Society के अमिताभ बच्चन, welcome.
Panelists will sit down over here. Okay. Dr. Vinita, please come pour in.
Vinita ma'am, belated happy birthday.
Happy birthday, happy birthday.
MPSOS के लिए बधाइयाँ मैम.
Happy birthday.
Yes, for all of us. हम लोग आपके ना पैसिव सपोर्टर्स हैं मैम, पीछे से तालियां बजाने वाले लोग हैं हम लोग. अभी कुछ नहीं कर मैम, ये पीछे
Shall we start?
सर आपके पास वो है ना शेड्यूल?
Yeah. हाँ.
पूरा है ना?
हाँ है. Good afternoon. Good afternoon, dear all. We welcomes you on behalf of the MPSOS. We are about to begin our session. I hope you will definitely love and like the session.
ऊपर आ जाओ ना, भसीन सर आप ऊपर आओ.
It delves into the details of intricacies
नीचे
of the cataract surgery with comorbidities.
कुर्सियाँ खाली अच्छी नहीं लगती.
I hope you love it. So may I call our first speaker?
Yes, already there, sir.
Dr. Rahul Shukla. He'll be giving the lectures on cornea and clarity, shedding light on. Please, sir.
Yes.
Shedding light on cataract management with coexisting corneal pathologies. But I still, there's a request to all the speakers to please adhere to the time limit because we have to cover them all. Please.
Yes, sir.
Rahul Shukla.
So good afternoon everyone. At the outset I would like to thank MPSOS for giving me this opportunity and congratulations MPSOS for getting this award. I'll be talking about cornea and clarity, shedding light on cataract management with coexisting corneal pathologies. So basically what are the associated corneal pathologies we are talking about? It could be a degenerative pathology, pterygium, a spheroidal degeneration or a BSK. Then you can have opacity due to trauma or a healed corneal ulcer. There could be high astigmatism or in case as in keratoconus. And then you have these, the post-refractive eyes with the RK, PRK and the LASIK done. And at times you have silicone oil, post-vitrectomized eyes, wherein the silicone oil causes corneal degeneration. And then you have systemic diseases. Wilson's disease is very common. And for the dystrophies, there's a huge list. But I would just shift our interest to Fuchs endothelial dystrophy. These are the commonest. And then what are the second thing, which is an ocular surface compromise. So there is just a very fine line dividing this. So it could be because of exposure to keratopathy, that's post-facial nerve palsy with Bell's, absent Bell's phenomena. You can have a limbal stem cell deficiency. You can have contact lens abuse, a neurotropic dry eye, side effects of ocular and topical medications, or trichic acid leading to any corneal degeneration or opacity. And finally, MGD, dry eye leading to distorted Myers with unreliable K values. Now these are things which have to be really kept in mind whenever you are talking to any patient, because the list which I have mentioned, more than 60 to 70% are going to fall in that, because this is one thing which is, cornea is the next in thing which has to be taken into account. So what do we do? Actually, we should treat the infectious keratitis first, be it bacterial or fungal. SPKs due to adenoviral keratitis need to be taken care of, because SPKs are really very notorious. They keep on coming. I mean, the reactivation of SPKs is so common, that has to be taken care of. When it comes to herpetic infections, you need to treat them, and the eye needs to be symptom-free for at least 3 months. And there is a debate on that. There are people who say it could be 6 months or 1 year. But then 3 months is the minimal time wherein there shouldn't be any treatment going on, and the patient shouldn't have any recurrence. Manage the systemic disorder and stop oblique change the oral or the topical medication that is leading to the corneal changes. And obviously we need to treat the MGD and the dry eye. That's very important. So what do we do when it comes to a preoperative evaluation? So what I do in my practice is I document as much as I can. So the corneal sensitivity is again very important. There are patients who have issues with the corneal sensation, and we just fail to check that. So this is one thing which we learned the hard way. There were patients who came back with neurotropic keratitis, and we were really shocked. Doctor, हमको तो समझ भी नहीं आता है, हमको तो कोई तकलीफ ही नहीं होती, and then suddenly you find that the patient is having absent corneal sensations. Schirmer and the TFN breakup time are one things which can be done very easily. Slit lamp photographs are needed. Document the layer at fault if we can do that, and it is very simple to do. Once everybody has a slit lamp में हल्का सा zoom करेंगे, slit lamp के slits beam up down करेंगे, you'll be able to find the layer at fault. pachymetry is important, and the specular microscopy is important. 700 cells per cubic millimeter is at least one thing which is important. Now, finally, corneal biomechanics, if all you have an access to CORIS, it is very good. And tomo and topography, whenever you have any patient with high astigmatism keratoconus. Now comes the most important part, that is the counseling. Now with the slit lamp picks, the pachy, specular count, tomo and tomography, everything in front of us, we have to ask ourselves first, is the patient fit for, number one, a cataract surgery alone? Number two, a cataract surgery or a combined PK or a lamellar keratoplasty, a DSEC or a DMEC? And if you have a central leukomatous or a nebular corneal opacity, you have to make sure that you mention it very clearly to the patient what the post-operative vision is going to be. Because this patient has come to you with a problem, and if you just treat the cataract and you leave behind a central opacity which is leading to glare at night, or for that matter, a loss of a line of vision, he or she won't be very happy. And make sure that a regular phaco causes around 7 to 10% of the endothelial loss. Now, stress on the visual prognosis and to the patient so that the patient understands and accepts the probable outcome. Planning a procedure, obviously you need to have a good specular count. Low IOP, slow motion phaco is definitely more acceptable norm. Low power of the phaco is very much important, and using the soft cell technique wherein copious amount of dispersive OBD, just make sure it underlines and it coats the endothelium so that you are preventing any corneal damage. And obviously, if you have major problems in the cornea consultant backup, if you're planning a second or a combined procedure. Now, this is a patient, it's a very old patient. Now, this patient had a BSK in one eye, and the cornea was not very healthy in the other eye. He had very high astigmatism, and he was told a monofocal lens. But as you can see, this was way back. One was done in 2015, second was done in 2016. This patient was given a smart toric lens, and the patient ended up with a vision of around 612. He was very happy. Obviously, gaon wala hai, he didn't mind that. But then leaving a patient with a cylindrical power of +5 or a +10 is absolutely not acceptable, at least on date. We have such smart lenses, and these lenses are not very costly either. The patient is ready to pay for that.
Your time is up, Rahul.
Yes, sir. Last case. So now this is again a case of post-classic. She had a very poor specular counts. She was counseled very well, probably need for a second procedure. Soft cell technique was used. We did pentacam. As you can see, the specular counts were not very good. We did multiple readings on the Argus as well as the Lenstar. We went in for the ASCRS online calculator, and to our surprise or to our, I don't know what, to our comfort, the patient ended up with a vision of 6.9, 6.6 with a -1 spherical. We targeted the patient with for -1, and this is day 1 post-op. So to summarize, identify the cornea pathology and its cause. We need to treat it if at all, if it's possible. We need to document as much as we can. We need to counsel and explain the plan and need for a second procedure. Combined procedures should always involve a cornea specialist, and low parameters phaco is important with a soft cell technique. Thank you so much for your patient hearing.
Thank you, Dr. Rahul. Nice and elaborate talk. Right now we are not dealing with the question answer. That can be dealt with in the end of the session for 15 minutes. So our next speaker, may I call Dr. Rajiv Chaudhary, sir? His topic is clearing the haze, managing cataract surgery with coexisting lens challenges.
Meanwhile, we can take one question. Wasim sir, any comment, question?
No, he is about to start. Yes, he is ready now. He's about to. Please, sir.
Good afternoon. My topic is the managing the cataract surgery with the coexisting lens challenges. There are multiple challenges we face, but we will going to cover a few of them. Normal surgery is a safe surgery, but we have some of the cases where we need a special precaution, and for that a preoperative evaluation with the aberrometry, slit lamp biometry, slit lamp, ASOCT is important. One of the most common is the posterior polar cataract. Typical circular defect, cookie cutter defect is found at the end. I will go directly to the surgery. Only thing, sometimes you can stent this, make a good mid-size rexis. Sometimes you have to put the lens on the rexis. Avoid hydrodissection, hydrodelineation, making a what old golden ring without rotation. Avoid sculpting deep and try to remove the lens matter as much as possible, pulling the cortical matter and lens fragment toward the central region. And you can easily remove the lens and put the lens. Another important is the pre-existing posterior camp rent. You can see that we are able to see that rent is already existing. Only thing we have stent the lens, rexis, will first one. Then removing hydrodelineation, low power, low phaco, to avoid to extension of that pre-existing capsular rent. Pulling the cortical matter towards the center is the important thing, so that the rent will not, and using the good viscoelastic behind this matter, so that that fragment and the lens matter will not fall down in the vitreous cavity. So removing this, now we have the rent, doing the good anterior vitrectomy with the help of tricot, so that you can detect that the vitreous stent, and then we can put the intraocular lens, able to put in the periphery and the remaining capsular support. You can say that the rent is still the same, and we are able to 3-piece. For this, a single piece lens is not suitable. Then we come to the subluxated cataract. This time is short. I will go to the one of the video where we stent the capsule, hydrodelineation. Now we have to see that lens is moving, so we use the capsular hook so as to cover the hold of the capsular bag, and once we have the good hold to capsular hook, sometimes you can use the iris hook also, but you have the special capsular hook for that. And once you have a good hold on the capsular bag, you can comfortably do the phaco in the low power and low flow mode, and removing this. Now bag is still weak, you have to put the CTR and suture it. So we have sutured the CTR. We'll skip that the 6 o'clock and complete the surgery. This one of the subluxated cataract. We can use the, I just wanted to show the iris claw in this. Once you are done, you can very well put it. Iris claw is very easy. And the same with the hypermature cataract, using the tripoint blue to stent. Good viscoelastic, especially I use viscot because it has a retentive tendency and it give a good pressure on the capsular bag, so you can do the rexis very well. Instead of Elon GB or something at P, I prefer viscot in this type of cases, because Elon GB and Elon just come out because I do with the forceps the rexis, and it is very easy to do with the forceps in this type of cases using the good viscoelastic material, especially the viscot. then the rest of the job is quite easier. You can do whatever the grade of the nucleus, complete the surgery. In the hard cataract, you have to use the good viscoelastic central, and you need a larger rhexis in this because the manipulation is more, so you require a larger rhexis in this case. And hardly half minute. Increase the power, repeated use of good viscoelastic and chopping, taking care that you will not give a good more stress on the zonules, and repeated use of viscoelastic, taking, you can see that it is hard brown, repeated use you can release. And so in a short, meticulous and appropriate surgical procedure can give good surgical outcome even in difficult situation. Thank you.
Thank you, sir, for the nice, wonderful presentation, nice videos.
Question next, can we ask later or?
In the end of the session. Thank you, sir. May I call upon the third speaker, Dr. Vinita Ramnani. She'll be speaking the clarity under pressure, illuminating paths through combined cataract and glaucoma challenges. There she.
Good afternoon, everyone. I will be talking about how to deal about a cataract as well as glaucoma, the coexisting ones. So cataract and glaucoma, they coexist, especially in elderly, and 30% of the patients, those who are going for a cataract surgery, will be having concomitant glaucoma. So we should all know how to manage such situation. So if it is you are doing only phaco, probably you can do it only in lens-induced glaucoma, that too in an early stage, or you can do it in early PACG cases. But if you are doing phaco alone, you have to be very careful that you have to check thoroughly for the post-op glaucoma, and you can continue with the post-operative anti-glaucoma drugs, but be careful about the post-operative IOP spikes. And it can be done in mild and moderate. But the best way is to deal both the pathologies, because we are dealing with both the pathologies, so we should address both. You can do glaucoma surgery first, followed by cataract. Especially in a very advanced glaucoma cases are cases where IOP is uncontrolled and where the cataract is not that high that you will not wait for 4-6 months. So this can be an ideal situation where you can do a glaucoma surgery first, but then there will be a progression of the cataract, and the patient will have a deterioration of the vision, and sometime you may have difficulty in detecting the glaucoma progression because of this progression in the cataract, and it can mimic like a glaucoma progression. So it becomes really difficult, and there will be no visual gain, so patient will not be happy because you are doing only the trabeculectomy. So you can do the reverse, the phaco first followed by a second glaucoma surgery. In that case, the cataract, if it is very mature, very advanced, and IOP is well controlled, then only you can go for a cataract first and then the glaucoma surgery later on. But then it also has a problem that if you do a cataract first and then you do the filtering surgery, it requires a special attention because there will be a small pupil, there will be an many other things which will give you a problem. So the best thing is to go for a combined surgery. So when you do a combined surgery, you can combine it with trabeculectomy, or you can combine with the valves, the MIGS, the non-penetrating, or endocyclophotocoagulation. Any procedure you can combine with the cataract, and the patient will be very happy because you are dealing both the situations together, and it works very well, and the patient has a rapid recovery, less follow-ups, and it gives the same results. So it is very comfortable procedure because going to one time into the theater, not twice, and it is cost effective also because it reduces the post-op visits, medications, and so many other things. But the disadvantage is it takes the longer time in the theater because you are doing 2 surgeries in comparison to the 1 surgery, and the patient may take a longer recovery time, maybe 6 weeks, to stabilize the astigmatism, and the visual outcomes can be delayed for little some time. Few studies reports that the IOP control is not that good. And it has lot many other complications because there are 2 surgeries together, so it needs expertise, and it becomes sometimes very challenging. I can show my one video. So this is a case of an angle closure glaucoma. Can you see that there are lot many ischemic areas in the pupil, and there is not a good dilating pupil, and there's a shallow anterior chamber. I make a Phoenix-based conjunctival flap and the scleral triangular flap with 15 number Bach-Packel knife, and go towards the clear cornea 1 millimeter deep inside. And once you reach there, then you do you can see the transitional zone. Then you can enter like your phaco, and you can complete the phaco the way you are able to do the phaco through the scleral tunnel. And once you complete the phaco, can I fast forward it? I don't have a control. So once you are done with the phaco, you can make an inner window. My God, it started again. So this is another case where the cataract is not that high, and you can make and see the triangular window over here very clearly. And then you do the phaco. Once you perform the phaco completely, then after putting an IOL, you can make an inner window. Probably I'm not able to fast forward, so maybe it's just a 1 minute video. So just do the cataract the way you are doing. Okay, let it be. Now inject an lens. And once you inject the lens, your assistant can hold up this triangular thing, and you can cut a rectangular window inside. I make little bigger window. Be careful that you have that pigment behind that the portion you have removed from the sclera. Do a PI. At this moment, usually I put a cycloplegic here so that there will be a proper maintained anterior chamber. I don't enter anterior chamber again and again, suture my flap, and ultimately with the Vicryl Tano, I put 2 anchor sutures and get the results. So it's a very fast surgery, very happening surgery because it's a single site surgery. So each method has its merits and demerits. Choose according to your patient decision, your own skill, and the patient's requirement. This is a chart I found very effective, that if it is an ocular hypertension, probably cataract surgery, mild also cataract surgery, but the moderate and severe cases, one site combined. But it is very advanced end stage. Basically, the 2 site combined will be the choice. And secondary glaucomas like uveitis or something, it's always 2 site, which works very well. Thank you so much, and I invite you all for Glaucotal 12, 13, 14 September 2015. Thank you.
Thank you, Dr. Vinitha. Combined surgery always poses a problem to everybody. It's always difficult to perform it, and that too so nicely. People may decide whether to perform the surgery, cataract first, or trabeculectomy first, or go for the both together. So it's always a challenge. Thank you, Vinitha. Next speaker, Dr. O.P. Agrawal. He'll be dealing with strategies for the cataract surgery in the presence of ocular inflammation.
Good afternoon. At the outset, I thank MP State Ophthalmic Society for giving me this opportunity. Clearing the fog. Strategies for cataract surgery in presence of ocular inflammation. We are all come across in cataracts having posterior synecdoche and inflamed eye many of the times. Many of the times we come across with lens-induced glaucoma patients also, which are having raised IOP as well as inflammation both. So what pre-operative strategies we have to plan? First, we have to control inflammation with the help of steroid, non-steroidal anti-inflammatory and cycloplegic. We have to optimize the ocular surface, reduce the dry eyes, blepharitis and any inflammations in the ocular tissues. Choose appropriate IOL like hydrophobic acrylic lens, which is better for this type of inflamed eyes. What intra-operative strategies we have to plan? We have to use anti-inflammatory agents before surgeries and use non-steroidal and steroidal corticosteroids during surgery. Minimize surgical trauma, which will reduce the further inflammation in the eye. And we have to use viscoelastic devices to protect the corneal endothelium and to reduce the inflammation. What post-operative strategies we have to plan? We have to plan that these type of eyes will have more inflammation post-operatively, and we have to reduce it and we have to maintain, and the post-operative follow-up should also be proper and repeated. So aggressive anti-inflammatory therapy, close follow-up and adjust treatment plan according to post-operative outcome. What are the special consideration we have to take care? uveitic cataracts, in cases of uveitic cataract, consider using इन सब का एक ही चीज़ है, steroid, non-steroid and cycloplegic. So these three things are very important to take care of post-uveitic cataracts. So by employing these strategies, surgeons can effectively manage cataract surgery in the presence of inflammation and optimize patients' interaction. These are few cases. The most important thing in these type of cataracts, we usually find posterior synechia. So we have to first dilate the pupil with the help of either spatula or Sinskey hook. We need three things. Number one, to separate the posterior synecdoche. Number two, to dilate the pupil. Dilatation can be done with sphincterotomy, can be done mechanically by stretching pupilloplasty or with the help of pupil expanders. Here I am doing very small sphincterotomy just to increase the size of pupil. Here one more thing is important. If we want to stain the lens, stain the anterior capsule, we have to stain the capsule under air, because once you will inject the viscoelastic there, and then anterior capsular staining will be much more difficult. So first inject the air, stain. Sometimes in very small pupil, I have injected the air and I am trying to remove the posterior synechia, separate the posterior synechia with the help of spatula. First I will try to dilate and then to stain, so that we can able to do proper capsulotomy. And many of the times we'll find this type of inflammatory membrane at pupillary margin, which we have to remove with the help of capsular access forceps. Once you will dilate the pupil, maybe semi-dilated pupil, if you are confident, you can go ahead with the cataract surgery. Cataract surgery is the same which we all are doing, but in semi-dilated or very small pupil, it is difficult. If the patient is having very hard cataract or grade 3 plus cataract, then even in a small pupil, cataract surgery is not much difficult. But if it is a Soft cataract in very small people, sometimes it is very difficult. So the most important is break the synecdoche, make the pupil properly dilated so that we can able to do surgery in this type of cataracts. Here, this is a very strong adhesions, and there is a strong fibrous tissue which is attaching pupil to the posterior capsule. Here, without removing this tissue, even we can do the cataract, but in post-operative period, this will give difficulty. I'm trying to pull it, but it was not possible. So I'm just cutting it at the level of pupillary margin, and then we can go ahead with the cataract surgery comfortably, so that even the post-operative results will be better. So this sometimes need patience. This is how the heart-shaped pupil and the simple single posterior synechia. Just separate it and continue with the cataracts, same cataract. The cataract surgery in all these cases will be same. So thank you very much.
Thank you, Dr. O.P. Agrawal, sir. You're playing with the fire. Uveitis with cataract is always so. Either if you are dealing excessively, then definitely you are going to have the post-operative problems. And don't deal it, then definitely the cataract surgery is difficult. So you're playing with the fire. Thank you so much. Thank you so much for the very nice, elaborative presentation.
Thank you very much. Thank you. I, on behalf of Indore Divisional Ophthalmological Society, I request all of you to please come and attend our ophthalmology tomorrow on 7th and 8th June 2025. This year will be a milestone for Indore Divisional Ophthalmic Society because we are celebrating our Golden Jubilee year. So please spread this to each and every member of MP State Ophthalmological Society and All India Ophthalmological Society to please come and attend. Thank you. Thank you very much.
Our next speaker is our star of MPSOS, Dr. Purendra Bhazin. He'll be speaking on the tiny eyes, big challenges, cataract surgery in pediatric patient. Dr. Purendra, please.
Thank you, Dr. Rajiv, for the introduction, and I am thankful to the MP State Ophthalmic Society and the chairperson on the dais for giving me these opportunities. I have been asked to speak on tiny eyes, big challenges, cataract surgery in pediatric patients. Indeed, a cataract surgery in pediatric patient is a challenge. It is different from what we do it in adult cases. They are congenital, they could be congenital or developmental or traumatic, and so management is different because the childhood cataract not only reduce the vision but also interfere with the normal visual development. Unlike the adult onset cataract, the stimulus deprivation amblyopia which is associated with it. So important considerations are the timing of the surgery, whether we have to do the surgery or not, or what type of surgery, whether lens has to be implanted, and to plan a staged or a single comprehensive surgery to implant IOL, or we can rehabilitate by contact lens or spectacles. And post-op visual axis opacification is another important aspect which has to be taken into consideration. Stability of the IOL presence and the high chance of decentration because of the excessive fibrosis. There is a pronounced inflammatory response to the surgical insult due to the cataract surgery. Post-operative amblyopia management should also be kept in mind in all these patients after the surgery. So, in patients with small central lens opacity, not significantly impairing red reflex, we can go for a medical management. We may dilate ask the patient to keep put him on dilating drops. But if the vision improves 6/18, then no surgery is required. And in associated corneal opacity, like in the case of Peters anomaly, where there is a central corneal opacity associated with central lenticular opacity and the nearly clear peripheral lens and cornea, optical iridotomy is the better option in such cases than the corneal transplant and cataract surgery. So when to operate? In bilateral dense cataract cases, early surgery at 4 to 6 weeks of age, and in bilateral partial cataracts, they may not require surgery or require surgery at the later age. Unilateral dense cataract, urgent surgery is required within days, and we should have a good anesthesia team to support us. Aggressive anti-amblyopia therapy should be followed after the surgery. Otherwise, if 4 weeks are passed, the nystagmus will set in and the dense amblyopia will set in a unilateral dense cataract cases. Although in most of the cases the results are often poor, after 16 weeks of age due to dense amblyopia, surgery is inadvisable in a small cataract. Partial unilateral cataract may be treated non-surgically. The management part is difficult because and we have to do a complete thorough examination. Along with it, we should take the history in detail, uncorrected and best corrected visual acuity if it is possible, pupillary reaction, IOP, slit lamp examination, fundus, B scan, and biometry should be done for both eyes, and we will be dealing in next slides. Retinoscopy, cover test, early photographs, and we should rule out the presence of retinoblastoma or the posterior segment pathologies. Various tests are pathological tests are done for each disease which are associated with the congenital cataract, like galactosemia, rubella, syphilis, Wilson's disease, etc. Coming to the IOL implantation, this provides a permanent correction, and this is the choice, and most of us we do the IOL implantation in majority of our patients. But coming to the IOL power calculation, which is the most difficult part in pediatric eyes, and because they are not the miniaturized adult eyes. The pediatric eyes are different because the cornea is steep, the lens is having the high power at the birth, and it may be from 34.4 diopters at birth to, and it reduces to 18.8 diopters at the maturity after 6 to 8 years, and this is the study results which I am sharing with you. And axial length increases from 16.8 to 23.6 millimeter. So even at the neonatal age, no, the slides are not moving further. इधर स्लाइड्स नहीं आ रही, इधर तो हो रहा है. So the eye varies so much from 16.8 to 23.6 millimeter axial length, and power decreases from 34, 35 to 18, 19 diopters, and the corneal steepness also cornea also flattens, but the refraction changes from plus 0.4 diopters to minus 0.5 diopters. This is the beauty of the nature. So numerous studies have found that IOL formulas for adult cataract surgery are less accurate in children because of all these changes, and we should go for the newer generation formulas, but still the residual refractive error will be too high in all these cases. Our goal is to undercorrect as myopia increases rapidly in pediatric age group, and younger the age, more is the undercorrection. In unilateral cases, greater undercorrection can lead to major anisometropia, and it is difficult to correct the amblyopia, so that has to be kept in mind. So pediatric biometry should be done, and I follow this rule of 7, that you decrease from 7 you decrease the age of the patient. If the age of the patient is 2 years, 7 minus 2, so you undercorrect by 5 diopters. So this is what I do, and other things are the Dahan's formula, 20% undercorrection below 2 years and 10% from 2 to 8 years. And the IOL power assumed as per the axial length also is suggested, but I am following the rule of 7. Some surgeons choose emetropia or myopia to help in the early management of amblyopia, but I undercorrect. This is a pediatric cataract surgery, which is slightly different from the adult cataract, and because the anterior capsule is more elastic, so there is a high tendency to extension of the capsular axis to the periphery. Secondly, we have to prevent it, we have to fill the chamber with viscoelastic, and the viscode is much better, or as Dr. Khokhar says, that we should use the heel-on to do this cataract. So lens matter is very soft, so bilateral irrigation or coaxial irrigation aspiration can be done, and primary posterior capsular axis I do in all cases in pediatric age group in our setup, because in our country these patients, they don't come up for the follow-up. So even at 8 years, 9 years of age, although it is recommended to be done below 6 years of age, and vitrectomy should be done from up to 4 years of age. This is primary posterior capsule, and 360-degree overlap of the anterior capsule, as you can see, it is here. It should be there in the IOL, otherwise decentration of the IOL is there. Another case, just a last case, and then we'll conclude with the permission of chair. And similar, I make a sclerocorneal section, as you have seen here. So this gives me extra leverage, and I don't have to put sutures unless the child is 1 or 1.5 years of age, and this gives me the tight wound, and the removal of post-operative removal of suture is avoided. So this case, the nucleus was dense, so we have removed it with the phaco, and at epinucleus mode. The ballooning of conjunctiva occurs because of we used phaco, otherwise we don't use phaco in such cases in sclerocorneal tunnel. Hydrophobic lens is suggested in all these cases, hydrophobic acrylic lens, and I don't use hydrophilic lens, and should be avoided in pediatric age group patients. And now I do with the vitrector, I am doing a posterior capsulotomy, and we can do at the same time we can do anterior vitrectomy also. So with this, there are different challenging cases also. So traumatic cataract, I thank you for your patient hearing.
Thank you, Dr. Purin. The real challenge with these kind of the cases is to prevent the development of amblyopia. If it has developed, I mean the approach is different, and while if it has not, but the challenges are different. Thank you, Dr. Purin. But may I request all the speakers to please adhere to the time limit, sir.
And take home message is you do pediatric cases and go with the car. Do pediatric cases and go with the car.
Thank you, Dr. Purin.
Which
Our
car?
next speaker, Dr. Alok Sen, a renowned vitreoretinal surgeon. He'll be speaking on the topic is a double vision dilemma. Navigating cataract
Hello.
surgery in patient with coexisting retinal pathologies. Dr. Alok Sen.
Good afternoon, and thank you for the opportunity. So I'll be changing gears from anterior segment to the posterior segment, and as it is said that there is no right or wrong way of doing things, it is just the perspective as we look. So some of the slides I will be presenting few cases. Someone would think it or manage it differently, but this is what I have learned over the period of time with experience. So there is a long list of retinal pathologies that can coexist with cataract, and not only they impact the vision, and it is difficult to differentiate whether the vision loss is because of cataract or retinal pathology, but it can have impact on the outcomes of cataract surgery as well. So the list is long. I will be restricting myself because of the want of time to few. So this is not an uncommon situation where you have operated an uneventful cataract surgery and a diabetic patient comes back with a fall in vision after 2 months of surgery. And what you find is a cystoid macular edema. So diabetics, they do have a very high risk of developing cystite macular edema, and this has to be kept in mind. And all of these patients, irrespective of what kind of cataracts they have to be put on a prophylactic NSAID for at least 3 months after surgery. Now, what in patients who have diabetic macular edema? Now, the diabetic macular edema can coexist with a significant cataract. And here, if you see that this patient had a vision of 624 with cataract and a center involving diabetic macular edema. So what we generally prefer doing in these cases is combining a cataract surgery with intraocular steroid or anti-VEGFs, so that we deal with both. As Dr. Vinita was saying, they were dealing with both glaucoma as well as cataracts. We try to deal with both DME and cataracts together. But you can always do anything else, like you can treat the DME first if the cataract is not very significant, or you can treat the DME post-cataract surgery. But always remember that after cataract surgery, the DME would increase because there is an increased chance of progression of DME. So your outcomes, because as cataract surgeons, you want 6/6 or even 6/5 visions. So it is better to treat DME first, or you combine it with cataract surgery. So these are the evidences. Now, what about PDR? Now, in patients with PDR, usually the patients with PDR progress very rapidly post-cataract surgery. So it is important that we treat these patients, as in this case, we started lasering this before we jumped in doing cataract surgery. We did laser, gave intravitreal anti-VEGFs, and the patient later on developed vitreous hemorrhage. That is when we combined cataract surgery with a pars plana vitrectomy, and this is post-pars plana vitrectomy. So in PDR, the risk of progression to high-risk PDR is very high after cataract surgery, and if possible, treat these patients before you go and do cataract surgery. One point of caution is that if you are unable to examine the posterior segment in a case of PDR in the other eye, please don't inject anti-VEGFs without doing a good thorough examination of the posterior segment. Now, coming to AMD, so it is also not very uncommon to find these patients who come with cataract and AMD together, and in our setup, usually the patients come with an advanced AMD. So the cataract surgery is the only option for them. But if you have an active AMD, then you can combine cataract surgery with anti-VEGFs. Now, there is a debate whether AMD progresses more after cataract surgery. I don't think so, but there is definitely a transient increase in retinal thickness after cataract surgery, although there is no evidence that there is increase in number of injections required after cataract surgery in patients with AMD. Now, macular roll and vitromacular interface abnormalities are also not uncommon to find with cataracts. Usually we combine cataract surgery with macular roll surgeries in these cases because the chances of progression of cataract after macular roll surgery is quite high, and as I said, you want a good outcomes. So combined surgery gives a quicker rehabilitation, it is cost saving and has less predictable, however it has got a less predictable refractive outcome, so that you have to take care of. Now, in ERM, there is always a dilemma whether to do a combined ERM peel or to do just the cataract surgery. Now, if you have a patient who has symptoms of distortion more than blur, then probably ERM is at the cause of it. And so a combined procedure may be beneficial. Similarly, if you do an OCT and you find that the foveal contour is grossly distorted, then that patient might require an ERM surgery combined with a phaco emulsification. But usually what we do is a sequential. So you do a cataract surgery, and if you find that there is problem, there is distortion, then you go ahead and do a ERM removal. This is because in most of the cases, and there is a recent meta-analysis also, they have suggested that in most of the cases, the ERM peeling may not be required at all. So another situation is, which is very common, is inherited retinal disorders like RP, which is the commonest one with cataract. And because in these patients, at least at present, we do not have much to offer, we usually do cataract surgery so that there is an increase, there is some kind of improvement in the vision that we can get. But one thing that helps you in predicting the outcomes of cataract surgery in these patients would be an OCT. And if you find that the outer retina is disrupted, the ellipsoid zone, the ELM, then these patients probably would not improve with your cataract surgery. So that brings to me to the point that whether we should be doing OCT in all our patients with cataract surgery. I don't know the answer, whether it is, as I said, there is nothing right or wrong in medicine, but what this meta-analysis tells is that OCT screening before cataract surgery picks up about 15% of macular pathology. And this is one of our case. You can see the fundus looks quite innocuous. And when you do an OCT, you will find that there is a type 1 CNVM with SRF. So in most, and this is more common with vitreoretinal interface abnormalities. So, and you can prognosticate your case by doing an OCT. So the jury is on. You can do OCT if possible in all your cases with cataracts. So to conclude, several retinal pathologies may coexist with senile cataracts, and cataract surgery in most of the cases with retinal pathologies are safe and they do improve vision. And post-operative evaluation and pre-operative evaluation and planning is the key to success. Thank you so much.
Thank you, Dr. Alok, for the nice talk. Our next speaker, I invite Dr. Gajendra Chawla.
Probably the OCT is now the baseline investigation for the cataract surgery. It should be done.
Dr. Gajendra Chawla will be speaking. Dr. Gajendra Chawla's topic is retinal reflections, cataract surgery in the shadow of operated VR patient, vitreoretinal patients. Dr. Chawla.
Probably EDOF is a option. You can go anywhere. EDOF and anywhere. You can avoid that advanced mono EDOF for there is one of the same thing that but you have to consult.
Not the multifocal. Not the
Not the
multifocal.
multifocal.
Sir, may I interrupt? Okay, because
Thank you, sir.
Dr. Gajendra.
Cataract surgery is the most complication of the VR surgery, and almost 65 to 80% patient require cataract surgery within 2 years of after the VR surgery. And phaco-vitrectomy combined surgery is being preferred nowadays in the patients above 50 years because of the such a high number of patients require cataract surgery after vitrectomy. Why this cataract progress fast is because of increased retroventricular oxygen tension, which is causing oxidative damage to the lens protein. There is an altered environment following the vitreous removal. There might be hydrogenic trauma, or we are using the intravitreal tamponade like gas or silicone. How we can have a successful phaco post-vitrectomy eyes? The preoperative consideration will be one has to do a very close examination of posterior capsule to look for possible rupture of posterior capsule during the VR surgery, and there can be a sign of phacodonosis or zonial instability. The IOL power calculation is always always challenged, and optical biometry will be always a better choice. If cataracts is too dense where the optical biometry is not possible, the immersion ultrasound is utilized. And when we are using this, it is in a more challenging when we are eye is filled with the silicone oil. IOL selection, again what we are debating, the greater risk of IOL tilt and decentration is reported in recent studies. Hence the multifocal IOLs and the other optically advanced IOL selection should be done with extreme caution if the oil is not, that eye is not filled with the silicone oil. When we are doing what are the intraoperative consideration? The postoperative eyes may have the exaggerated anterior chamber depth due to the lack of support and the low scleral rigidity. So one has to keep what is the solution? One has to keep the infusion pressure low. Then giving the retrobulbar and subtenon block may provide some posterior support. One has to take care of the proper wound construction, and when handling or removing the surgical instrument, it should be removed slowly. one should make the short tunnel to avoid the corneal distortion due to the use of the vertically oriented instrumentation in the long tunnel incisions. Iris lens diaphragm retropulsion syndrome, or LIRDS. It is because of the laxity in iris lens diaphragm, in which the pupil border may stuck with the anterior lens capsule, resulting in the trapping of the fluid in the front of the iris and thus increase the anterior chamber depth and pressure. So when you are going in, please lift the anterior capsule with your chopper or another blend instrument and maintain the fluid equilibrium. Capsular axis is again challenging, so one can use the trypine flu dye for stunning of the better visualization. One can use the cystatum to raise the flap and then complete the capsulotomy with the forceps. Avoid hydrodissection in the presence of possible posterior capsule trauma or touch during the vitrectomy, and in such situation hydrodelineation and viscodissection are the safe. One should do a very slow and gentle movement while during the surgery, and if we are suspecting there is a zonial dialysis, one should be take more cautions. Careful and complete removal of the viscoelastic material should be done to prevent the post-operative inflammation and the raised post-op IOP spikes. Sometimes we are having the situation where the silicone oil is in situ and there is a cataract is progress, and the VR surgeon don't want to remove the oil because of the retinal pathology. So there are certain challenges in those particular signs. Sometimes there is an emulsification silicone in the back of the cornea, so one can remove with the use of OVD. If it is simple, some emulsifying bubble, it can be removed very easily, but when there is a lot of silicone oil, one has to because it is because of the hypotony probably, so we can use we should avoid the perivalvular blocks in such situation, or no compression after the perivalvular block, and one should use the continuously use the viscoelastics in every steps. Remove, if there is large bubble, one can use remove with the phacosuction also, but if large amount is lost after the surgery, one should supplement it with the more oil. If there is an extensive synechia, Dr. O.P. Agarwal has already covered it well. You should break the synechias and use the viscoelastic, but keep caution not to damage the anterior lens capsule. Non-dilating pupil again is a challenge. So you can use the mechanical pupillary stage by injecting more additional viscoelastic, or use Y-shaped iris spatula or pupil expander, like the things one can use. There is a shallowing of anterior chamber because of the silicone oil is lighter than the intraocular fluid and it is floating anteriorly, which is pushing the posterior capsule. So use a good amount of visco always after every step, and remove the surgical instrument very slowly. There, because of the silicone oil, the posterior capsule capsular plaque will be very dense. So don't try to remove it. Don't try too much to remove it, and one can use the YAG capsulotomy in the later on. IL power calculation is again challenge. Optical biometry is the choice, and if you are using the ultrasonic biometry, you can multiply the axial length by converse section of 0.71. So there is a small video. If we are not having time to, I'm not showing that, but it's just 30-second, 40-second video. There is a bubble in the anterior chamber which we are removing just with the infusion cannula. And because we have seen so many videos and we are having two more talk, I'm skipping this. So to conclude, phaco in the post-vitrectomy eyes with or without silicone oil is a challenging situation, and it can be managed successfully by modifying some surgical step for the maintaining anterior chamber stability. Thank you so much for patient.
Thank you, Dr. Gajen Chawla. Only a good manager can do it. That's skipping the part of the video. Thank you so much.
Thank you, sir. Sir, being the leader of the MP State Society, I have to take the care of it.
Thank you so much. Our next speaker is our scientific committee chairperson, Dr. Shweta Walia. She'll be speaking on beyond the eye, systemic consideration in cataract management. Dr. Shweta.
Good afternoon, everyone. I am very much thankful to MPSOS and AIOS APO for giving me this opportunity. So today I am speaking on systemic considerations in cataract management. So whenever there are systemic comorbidities, it adds up to the investigations preoperatively so that we can get a fitness for the surgery. Now, we need to sometimes change our surgical approach to minimize the intraoperative complications and do preoperative investigations, and many times there are post-op precautions also that need to be taken. So diabetes has already been taken in depth with by Dr. Alok Sen, and I am not going into the management of diabetic retinopathy and diabetes, but since one point of line I would like to add is how diabetes impact our cataract surgery. There are biometry challenges, there is delayed healing, there is increased risk of infection, and there are chances of progression of diabetic retinopathy. Now, for diabetes, the fasting blood sugar needs to be kept below 140 and postprandial less than 200. And we all know that OCT is a must in patients with diabetes. Now, coming to a patient having hypertension, in the patients who are having high blood pressure, the BP needs to be controlled. Many times intraoperatively there are sudden BP spikes and fluctuations which can increase the chance of choroidal hemorrhage, expulsive hemorrhage, vitreous loss, and this can lead to poor visual prognosis. And also many times there are increased chances of posterior capsular rupture. Also there is endothelium is in stress and there can be corneal edema. So the BP must be kept less than 160 by 190 mmHg, and many times we have to keep anesthetists standby, and they can give labetalol in the doses of 10 to 20 milligram IV over 2 minutes, and if needed that can be repeated after 10 minutes until the BP is controlled. So BP should be well controlled before the surgery. Now let's take a case of a patient who is on anticoagulants or has a low platelet count. So we usually are not stopping anticoagulants before the surgery, but the patients who are on two anticoagulants like the aspirin and clopidogrel, so for them aspirin can go on and we need to withhold clopidogrel, and we also need to see and weigh the thrombotic versus bleeding risk and stratify the patients whether they are high risk patients or at low risk patient. These are the conditions given by the American College of Chest Physicians, and these are high risk patients, and these must be taken with the anesthetist and after cardiology fitness. Now a patient who is on tamsulosin is a high risk for floppy iris syndrome, and the surgery must be done with the great care. The parameters must be kept to low, the bottle height should be low, the fluctuations in the NTH chamber needs to be kept to the minimal, and if needed we can use pupil expanders, and you can see this pupil is small, and still the surgery can be managed if we keep the parameters to low. Now a patient who is having Parkinsonism or dementia, they can't keep still for long times, and they usually have tremors which can affect the eye stability. So these patients can be kept under short sedation, and we can avoid topical anesthesia in these patients, and anesthetist standby is a must for these patients. And if needed, we can put a suture on the incision, and we must see for the post-operative compliance for the patient. So now RA patient who are on long-term steroids, and these patients also have associated dry eye. So what preoperative considerations we need to take into care is that these patients usually have ocular surface disease, the dry eye, episcleritis, scleritis, and they are at risk for poor wound healing, and also there are chances of cystoid macular edema. So we usually prefer doing it under topical anesthesia and a clear corneal incision. We'd avoid giving a scleral incision. SICS is a big no for RA patients, and optimize the dry eye with lubricants preoperatively. And since they can have neck rigidity also, you can use intraoperative adjustable headrest, tilt the microscope for comfortable positioning, and post-operatively we need to avoid prolonged steroid use because they are at risk for glaucoma and delayed wound healing. Now, a patient with kyphosis is a big problem when we are operating him. SICS can be done very easily by managing the position of the patient, but when you are planning the patient phaco, a reverse Chandler position is a good option. And Dr. O.P. Agarwal sir is a big expert in operating kyphosis patient, and we are all aware with the videos he has many times shown us. So these are the various positions that we can make and do comfortably the operative procedure. Now, a patient who is seropositive with HIV and is on ART with mature cataract, in those patients, a preoperative CD4 count is must, and these patients are at risk for opportunistic infections, and a clearance by the physician is must, because many times we need to give post-operative steroids also. Also, these patients have bleeding tendency because of ART-induced thrombocytopenia, and this must be kept into mind. Along with that, standard universal precautions should be followed, and these cases must be kept for the last case of the day, and instrument sterilization should be done properly at the end of surgery. Similarly, for HCV patients, these are at bleeding risk, and there are high chances of intraoperative and postoperative inflammation. So PT-INR count, liver function test, and viral load preoperatively must be checked. Now, case with the Alport syndrome, this is the case of a 12-year-old child who is having a renal failure, and on examination, the child had a lenticonus. So these patients, because of lenticonus, are usually amblyopic, and amblyopia management must be done at the after the surgery. And during surgery, we can go for a PPC with vitrectomy. To conclude, systemic comorbidity impact cataract surgery outcomes significantly, and a multidisciplinary collaboration with the physician and cardiologist is a key. And preoperative optimization can reduce the intraoperative and postoperative complications. Thank you.
Thank you, Professor Shweta, for the very informative talk. Thank you so much. Our last speaker, Dr. Amit Porwal. He'll be speaking on clearing vision in injury, navigating trauma and cataracts in tandem.
So I thank MP State Ophthalmic Society for including me and including this state symposium. And I'm going to talk on managing cataract in a basically traumatic cataract. My slides. So we all know that the most common trauma what we experience is either a penetrating or a blunt trauma basically. So I'm going to show some surgical videos of how to manage this. You can start the slideshow from this. छोड़ मैं कर दूंगा. Yeah. So this was a case of basically case posted for phaco, status post RD, traumatic RD, iridodialysis was there, ZD was there. I inserted a CTR and SOR was done along with the same case. So whenever we do the side port, we have to be very careful. There is a scarred cornea also. So we have to do the side port in such a direction that visibility is not obscured. You can see the whole anterior capsule is fibrosed and it is like a shrunken. So you have to be very careful when you are doing the rexis, especially when you have a ZD. So it is not necessary that you have to do the rexis always with the capsulotomy needle. You have to be used to performing the rexis both with the rexis forceps as well as the needle. Gentle multiple small aliquots of hydrodissection is done so that the cataract is not collapsed, and I do usually multiple delineations. In this traumatic cataracts, they are very soft, so the more the number of delineation rings you have, the easier it is for you to aspirate, so that you don't have much pressure, you don't give much pressure on the zonules or the capsular bag. So just in the aspiration mode, you can see because of the traumatic cataract which are very soft, it comes out easily. Now because the ZD was there, I inserted a CTR. Again, I would advise that instead of doing a manual CTR insertion, you can see that when I was inserting a CTR, it was not going properly. properly. Why? This can happen because if there is a fibrosis or the bag gets collapsed. So I took out from that end and I approached to the other end, and you can see when I'm putting to the other end, the CTR gets nicely rotated and implanted into the bag. And my advice would be to always use a preloaded CTR, especially in case of traumatic cataract, because the control is much better with that. If the rexis is intact and you have placed the CTR, you can place a any lens depending on the state of the cornea and the retina. So in this case, I was trying to separate the iris and was thinking of doing the pupilloplasty, but the whole iris was fibrosed and shrunk, so I couldn't do the pupilloplasty. So I just left the pupil like that only, posted the case for SOR, and then they managed the pupil there. Second case of traumatic cataract again. You can see this was a perforated injury was there. So there is a corneal perforation, the iris is perforated and the anterior capsule is perforated, because of which there is a cataract. So after dilatation, I'm trying to separate out any synechiae which are there, and trying to visualize if it was a very foreign body. Preoperative investigation was done. So coming to the rexis, we don't know what is the status of the lens behind. So whenever you are doing the rexis, you have to be very gentle, especially here. If there is a fibrous or calcified end, then the rexis can get extended, and that's what happened here. When I was doing the rexis at the calcified area, the rexis went beyond it. So I took the rexis back into the center, so that at least I have the optic cover on the other side. Now because this was a perforated self-sealing corneal tear, but it has irregular ragged edges. So you can see when I'm suturing this edges, you have to make sure that you oppose the cornea in the proper way, so that the edges don't overlap. So you might, this was a ragged edge, so you can see I've put 2 horizontal sutures, then there will be another horizontal suture at a different level. So the aim should be to maintain the contour of the cornea without causing much damage, and the edges has to be opposed properly. There should never be any overlapping of the edges. Now it is a closed chamber, so multiple, as I told you, hydrodination is done, and this was a very soft cataract, no need to use the phaco probe. Just with the biomanual, you can aspirate all the cataract. And while you are doing this, you saw the pupil is getting constructed. So you need a retro illumination in this patient. Your microscope should be having the facility. And as I'm aspirating, you can see the glow is changed. So what the glow is changed means, there was a pre-existing PCR, which while aspirating, we noticed that the PCR is extending. So pre-existing PCR can be a possibility in any penetrating injury. So you always do a tricot strain vitrectomy. Never do a vitrectomy without straining with the tricot, because tricot usually helps us in visualizing the vitreous strands. So do a bimanual tricot strain vitrectomy. A proper vitrectomy is must. Separate all the tissues which are from the vitreous, and always keep a 3-piece lens at the standby. Whenever you are dealing with any traumatic cataract, make sure that you have a 3-piece lens, because you never know what is the state of the capsule or the posterior capsule or the bag, and 3-piece lens comes very handy in this. So in this case, this 3-piece lens was inserted into the sulcus, and the optic capture was done, and whatever Simcoe was there was washed with the help of a Simcoe cannula. So no need that you should always use a biomanual. You can also use a Simcoe cannula, which is very handy and it's very helpful. This is another case of traumatic subluxated cataract. You can see the ZD which is there inferiorly. So in this case, SICS was planned. Why SICS was planned? It is not any particular choice that because this cataract needed SICS. It is basically the affording of the patient, what patient was affording, that package we have taken. So staining of the capsule is very, very important in these cases, because you want the capsule to be stained so that it can be easily visible. Initially, after the first rupture, you saw the whole milky cataract cortex is coming out. So what you can do is, to have a good rexis, you can fill this bag with a high density cohesive viscoelastic substance. There was calcification. As I am doing the rexis, the whole ZD went on increasing. So in this case, I have prolapsed the nucleus into the anterior chamber. Then after injecting enough visco, the nucleus is delivered. Now whatever bag is there, because the ZD was so much, we took out the bag and then we planned this patient for an iris flow IOL. So without causing much trauma to the patient, we can give good vision, do a tricot strain vitrectomy. Then because this pupil was fixed, dilated pre-operatively, I'm trying to pull in the iris so that we can have a small pupil, and something like a mechanical pupilloplasty. So once you have done that, you know that the pupil has constructed, then you can place an iris claw. So the iris claw lens is less traumatic in this type of cases. Instead of doing heroic surgeries, I think whatever works best in your hand, that should be done. So an iris claw implantation was done, posterior fixation, and a peripheral iridectomy was done with the help of a vitrectomy cutter only to prevent secondary glaucoma. So there are various ways of handling the traumatic cataract. Do what works best in your hand. Most common causes are blunt trauma, and subluxation will be the most common, or there can be a penetrating injury. Thank you.
Thank you, Dr. Amit, for finishing it so fast. Thank you. Do we have the time? Can we take up the questions? So I'm thankful. I'm really thankful to the audience. Thankful to the audience for patience hearing. We can please, we can have the photograph here. We can have the group of please assemble. Yes, I have called everyone.